Ingram. I'm director of the Office of Drug Control Policy, and came to there about 15 years ago after a career in law enforcement. And you might be asking yourself, why does an old policeman care about, why is he involved in Medicaid and 1115 waivers and all that kind of stuff? Well, I really believe one of the best tools we have to get out of this horrible opioid epidemic that we're in is the substance abuse benefit within Medicaid. We're not going to rest our way out, we know that. We're not going to pass enough laws to prevent the diversion and the abuse of opioids. So our best hope is treatment and recovery. And that's what makes you all so important to our mission is your willingness to be Medicaid providers and take care of some of the most vulnerable Kentuckians. As most of you know, we lost 1,565 folks in this state last year. That's 4 people every day, statistically. That is just not acceptable. And we've got to do better. We've got to improve. So that's what made me excited when the 1115 waiver process came along, and I learned that substance use disorder was a big part of the waiver. And as you know, we've been working on this a long time, and it feels like forever. But we're finally making some headway. Our implementation plan was finally approved by CMS just a couple of weeks ago. So what's left is a state plan amendment and some new regulations to guide us moving forward. But we're getting there. So one of the things we hope to do, or are doing, is the 16-bed IMD exclusion is to be waived. And that 16-bed limit is to be waived for providers that are offering a full continuum of care. What do we mean by that? Well, residential providers that are also providing MAT is one of those key points. Now it's kind of interesting, we're kind of at an impasse here because when we wrote the waiver, the SUD portion, we said a provider had to, a residential program, would either have to provide MAT inside the walls or have access, have a way to show access to their clients outside. It would be like an MOU with a local provider to get that medication. Then the president signs the opioid law last week, the big HR 6 package, and it also removes the 16-bed limit starting in 2020, but it says MAT, both an antagonist, Vivitrol, and a partial antagonist, buprenorphine, has to be done on site within the residential program. So we're going to have to get some clarification from CMS. I don't see a lot of positive side for us starting with one set of rules in June and then have a new set of rules in January. So we're going to have to take a hard look at that and talk to CMS and get some clarification on that. Also talking about that full continuum of care, we expect a plan when somebody leaves that 30-day residential program. What is the plan for this patient? If they're going back to their community and their community is not the same place where the program is, do you have agreements with a provider in their community to continue on with their outpatient treatment, with case management, with peer support, all those things that we know are so important when someone's going back to their community after being treated for their SUD or OUD. I'll be frank, I've seen some programs where it's kind of like pat you on the back and wish you well after your 30-day stay, and that's just not acceptable. That's not what we're going for. And we've talked about this, Christy, since day one, that we wanted to improve quality of the treatment being offered for SUD patients, not just lift the cap, but to improve the quality of what's out there. Many of you are familiar with House Bill 124 and the work that we've been doing with licensing and regulations to improve quality. Well, the 1115 is all about improving quality as well. One of the other big changes is adding methadone to the covered benefits that we have. The first 10 years I was on this job, we stayed steady at about 3,000 patients within our 11, 12 methadone programs. We now have over 26, 27 around the state, and we've got about 9,000 patients and growing in that population. There's a lot of history with methadone. There's a lot of study, a lot of evidence, and it's very effective for a subset of patients to be on, and it saves lives. So we're excited to be able to provide that benefit, hopefully at a bundled rate, a daily rate is what we're going to be looking at, and that will provide for counseling, both group counseling and individual counseling, case management, and some peer support. The only thing that we have a waiver on from the methadone program is non-emergency medical transportation. Going all the way back to the Bashir administration, we looked at this in 2014, 2015, and the transportation cost, frankly, is what scared us off as a covered benefit, because there was no way to predict how many of the 9,000 or 10,000 folks that are in Medicaid receiving a methadone would meet that challenge of requiring non-emergency medical transportation. So with only 26 programs in a state this large geographically, taking somebody once a day to dose, maybe 60 miles round trip or 70 miles round trip, could certainly cost a lot of money, could add up, and it was just too much of a burden. So we have that exemption from CMS, except for folks 18 to 21 who are coming out of the foster care system and pregnant women. We will provide transportation for those two vulnerable groups. But other than that, the transportation part has been waived. One of the other things that's important is we're getting folks in the right level of care. So our managed care companies all use the ASAM criteria. I don't know how many of our providers do, but it's a good tool, it's a good assessment tool, and it's readily acceptable. So we'll be looking at that and looking at what providers are using, but I'll tell you, we kind of lean towards the ASAM model. One of the things that we'll be looking at is in our agreement with CMS is where the gaps are in this state, and there's a lot of them as it relates to all levels of care, specifically MAT, but really all levels of care. We have gaps in this state. We need to work towards filling those gaps and figuring out ways to incentivize providers to go where there's a need but not much treatment at this point. So that's more of what we'll be looking at. We want to improve the care coordination between levels of care. As you know, you can't presently bill for case management while a person is in a residential program. I hope that's something we can take a look at in the future, of being able to do that at least in the final days when someone is leaving a program. Because it's that coordination back home is so important. So as I said, our short-term residential stays up to 30 days. We also are allowing for BHSOs to do partial hospitalization. So the folks that have the right levels of clinical staff that want to do partial hospitalization will be able to do that. And I think that will be a nice add-on. I think I've covered just about everything we wanted to talk about. I've got a few minutes I can take. If you don't get me too far in the weeds, I can take a question or two. If we get too far in the weeds, I'll have to bail on you. Yes, sir.
Are there any announced plans for the San opioid or behavioral health hospitals being built in the next year to 2 years in Kentucky?
I haven't heard of any. I do want to mention, I say I haven't heard of it. I have heard, we have had some discussions with one group that I'm aware of. So that's a possibility.
Was it US Health Best by chance?
No.
Okay. They just are putting a 100-bed unit in Indianapolis.
Okay.
They're just starting to break ground on that.
You know, I'll be real frank with you because that's what I do. That's something we worried about when we lifted the 16-bed cap was some conglomerate coming in here and opening up a 600-bed facility. You know, so with 16 beds, you can have that home-like environment and a therapeutic environment. You can't really have a therapeutic environment with 500 patients. So that's something that we're going to watch closely and be very cognizant of. I think right now we've set the limit at 198 beds, if I'm not mistaken. But yeah, that's a concern. That's not to say you couldn't do 198 and have them separated out enough to where it looked right, you know, and it could work. But if you're going to warehouse them in a big old building, I'm not for, you know, that's not what we're about. One part I failed to mention, I talked about bundled rates for MAT, for methadone. We also want to look at doing the same thing for our office-based treatment programs for buprenorphine. We're kind of all over the place. I've met with several providers, need to meet with more and figure out, you know, what should be covered, what can we cover, and what that should look like cost-wise. But the idea, let me go back just a minute. You know, the last 2.5 years working really closely with Cabinet for Health and Family Services, our goal has been, and we talk about it every time we meet, is removing barriers, getting as close to treatment on demand as possible. And that's one of the things we're looking at with these bundled rates is removing barriers for the providers. So you don't have to go through billing 5 different codes and struggling to get paid. That if you can get approved with a bundled rate for this patient and they're your patient, you take care of them for this rate, and hopefully that will remove some barriers for providers. Improving quality and getting as close to treatment on demand as possible, I think, is our best chance to dig our way out of this epidemic. Yes, ma'am.
I have 2 or 3 short questions. As far as facilities, have you considered using open space in existing hospitals or other medical treatment facilities where you could put a 16-bed spot in there, and that would serve the need possibly of getting a center someplace where, say in eastern Kentucky?
We've looked at some properties and we've met with public and private providers. No action yet, but the Department of Corrections has put out a request for information on doing something like what you're talking about for our folks that are on probation and parole and are struggling. I know you didn't come here for a justice talk, but people failing drug tests or not showing up to take their drug test because they're going to fail it is the largest driver of our prison population right now. And so that's something we're working hard to get a handle on, because most of the time it's folks that are failing, relapsing with their substance use disorder. So that's one of the things that we're looking at. Did you have something else?
Yes. Do regulations exist for this yet?
They're in draft form, working their way through the cabinet, along with the state plan. I don't know, I think mid-December probably, those will be ready to look at. And I don't know whether it'll be an E-reg or a regular reg, so.
Probably E-reg, but it'll be publicly posted.
So it would be
E-reg.
effective in March or so, if that's the case.
And my final question was, is this program going to run separate from
a good question, that I'm not sure I understand. So, they are two separate things, and this has been finalized and we're moving through with it. As for where Kentucky Health is, couldn't tell you. I kind of stay in my lane, and my lane's the SUD portion, so I'll let Tracy address that when she comes up. Thank you all, I'll be with you. I apologize now, I have to cut out, I have another meeting, but hopefully we gave you some information you can use.
Thanks, Dan.